Hi everyone. Welcome to Pharmacology Module 6. We're going to discuss gender health problems, chemotherapeutic agents, and anti-rheumatic medications. So specifically, we are going to briefly describe some women and men's health and the drugs that are used to treat them, and talk about all the things we always talk about, their mechanisms of actions, their side effects, and nursing considerations for each of them. Specifically, we are going to talk about hormones, osteoporosis, BPH, and erectile dysfunction. We are going to talk about anti-neoplastic agents, biologics, and cell cycle specific anti-neoplastics, as well as anti-rheumatic drugs. So let's get started. Wonderful nurses to be. Okay, so gender health problems. So chapter 34 talks about women's health drugs. So the female sex steroid hormones, which are estrogens and progesterone, and then the pituitary gonadotropin hormones, are the follicular stimulating hormone and luteinizing hormone. The female sex steroid hormones and pituitary gonadotropin hormones promote the development of primary and secondary sex characteristics and the start of menses and regulation of menstrual cycle. So very important things. I've been a nurse for almost 30 years, and so I've seen a lot. And one interesting thing I saw was a young woman who had developed only on one side of her body. So all the way down the line. So like her left breast, her left labia, her everything left wasn't developed, just the right side. And so it was something to do with this pituitary gonadotropin hormones that only developed on the one side of her brain and not the other. Fascinating. And so, I think people take for granted that these sex steroid hormones and, that develop the primary and secondary sex characteristics and all those things, you just assume that it takes place normally for people, and you don't really think about some of these really rare abnormalities that take place and the consequences for these people's lives and the surgeries, etc., that they end up having to try to correct it. And so there's just so many things about the human body that until it goes wrong, you don't think about it. I always say to people, if you don't think your health is the most important thing in your life, then, I'm sort of a health nut, but if you don't think your health is the most important thing in your life, you've never lost it. And I really think that's true, because people just take it for granted until, something goes wrong. And then you're like, wow, I have to think about breathing, or I never had to think about what I had to eat before, and now I have to take insulin. Just so many things that people struggle with. Okay, so 3 major endogenous estrogens are the estradiol, which is the principal and the most active, the estrone, and the estriol. So these are synthesized from cholesterol in your ovarian follicles. It's the basic chemical structure. It's very similar to a steroid, but it develops and maintains the female reproductive system, that develops the female secondary sex characteristics, shaping of body contours, and development of the skeleton. So these are indicated for the treatment of many clinical conditions, primarily those from estrogen deficiency. Of course, if you're running out of estrogen, that you need to replace the estrogen. The smallest doses of estrogen that relieves the symptoms is what's used. And so some people, there's a lot of different estrogens now that people take, from taking an estrogen pill to bioidentical hormones. But the really important thing here is just take enough, because you really don't want too much estrogen. You just want enough to relieve your symptoms, and that's it. So the estrogenic, the synthetic, so there's steroidal, which are conjugated estrogens, estradiol transdermal, estropipate, and then many others. And then there's the non-steroidal as well. These are no longer available in the United States. The estrogenic drugs, here's your long list. I won't go through all of them. You have them in your book, but there are quite a few estrogenic drugs, and it just depends. Sometimes there'll be a newer one that comes along. There's different side effects, and they do maybe minor different things, but essentially estrogenic, genic meaning from the beginning, these help produce estrogen when people don't have any. So why would we take estrogen? So it treats or prevents disorders that result from estrogen deficiency. This is an easy one, you guys, right? So what are some of those things? It's not just, people are in menopause and they take estrogen. That's what people think of right away when you think about estrogen replacement. But there are a lot of uses for estrogen. So here are some of them. There's atrophic vaginitis, hypogonadism, Oral contraception, and so of course they give a little bit of estrogen with progesterone in most birth control pills. Uterine bleeding, vasomotor spasms of menopause, which is hot flashes, which is what people think of. Osteoporosis with treatment or prophylaxis. Breast or prostate cancer, it can be a palliative treatment, and then ovarian failure or castration or removal of the ovaries. So why wouldn't you take it? If you're allergic, if you have an estrogen-dependent cancer, and so here's where the risk lies. So I worked in oncology for a long time, and one of the tests we would do, like for example, if someone had breast cancer, we would do a test to see if it's estrogen receptor positive or negative, ER positive or negative. And then the treatment is completely different because there's been so much research on breast cancer. It's one of the most researched cancers. I always said when I was in oncology research that it's somebody's mother and aunt and sister, and so it just happens to be the most researched cancer. I'm guessing, but I'm pretty sure of that. And so we just know so much about it, and so if it's ER positive or ER negative, it's a totally different treatment plan, and so it's super important. So if you had an estrogen receptor, where if you had a cancer that was dependent on estrogen to grow, you're not going to want to take estrogen. And so that's where the risk lies, that people are like, oh my gosh, I don't want to take estrogen. I'm afraid I'm going to feed cancer that I don't even know I have. And that is a real fear. And I mean, it's a legitimate fear, I should say. But then you look at all the treatments. You look at, do you want to get osteoporosis? Do you have all these other issues that estrogen helps? And so that's why only take as much as you want, not too much. And then, you would tell these people to have regular mammograms and self breast exam and things like that to catch things. Contraindications also, you don't want to take it if you're pregnant or if you have an active thromboembolic disorder or history. So some of the adverse effects of estrogens are there can be thrombolytic events. So that's the most serious, is you can have a blood clot. Nausea, that's the most common. Then people can have hypertension, thrombophlebitis, edema, vomiting, diarrhea, constipation, abdominal pain. It can cause photosensitivity, amenorrhea, headaches, tender breasts. It can interact with oral anticoagulants, and so you have to be careful. Direct effect of rifampin. It interacts with St. John's worts, which a lot of people take for depression, and also with the tricyclic antidepressants, and it can interact with smoking because smoking also increased your risk for thrombolytic events. So here's some current studies, and so the recommendations support the initiation of hormone replacement therapy around the time of menopause to treat menopause-related symptoms, but not really for the prevention of certain disorders such as osteoporosis or fractures. And so this is current research. It is not recommended for women with a history of endometrial or breast cancer because of what we just talked about. Progestins, and so here's the list. This is in your book. I'm not going to go over word by word, but lots of progestins. So how do progestins work? And so induction of secretory changes in the endometrium. They increase your basal body temperature. They thicken the vaginal mucosa, relax uterine smooth muscles. They stimulate mammary alveolar tissue growth. And it also is the feedback inhibition of the release of pituitary gonadotropins. So why would we take a progestin? So what are the indications? So it treats functional uterine bleeding that's caused either by a hormonal imbalance, fibroids, or uterine cancer. It can treat primary and secondary amenorrhea. It can be used as an adjunct or palliative treatment for some cancers or endometriosis. It can be given alone or in combination with estrogens to prevent conception. It can prevent a threatened miscarriage, and so you'll see sometimes people are having their progesterone levels tested to see if they need extra progesterone. And it also can alleviate some PMS symptoms. So why wouldn't we take them? What are the adverse events? So it can cause liver dysfunction, thrombophlebitis, thromboembolic disorders such as a PE, nausea, vomiting, amenorrhea, edema, weight loss, and there are others as well. So medroxyprogesterone. So this inhibits the secretion of the pituitary gonadotropins, which prevent follicular maturation and ovulation. They stimulate the growth of mammary tissue, and they have an anti-neoplastic action against endometrial cancer. Anti-neoplastic. So neoplasm is, cancer, and so an anti-neoplastic action would be against cancer. It can be used to treat uterine bleeding, secondary amenorrhea, endometrial cancer, and renal cancer. It's also used as a contraceptive. So Depo-Provera is a birth control pill that you'll hear about. So that's really the name you'll hear more is Depo-Provera. So contraceptive drugs, what are they? They're medications used to prevent pregnancy. When you hear somebody say, oh, I'm on the pill, that's usually what they mean, that they're on a birth control pill. So oral contraceptive medications, there are many of them, monophasic, biphasic, and triphasic forms. So the triphasic form most closely duplicates the normal hormonal levels of the female cycle, because the female cycle, it's not the same every single day. So the triphasic mimics more of what a female's hormones naturally do. There are newer extended cycle products where people don't have a period for 4 months, and there's all sorts of different things that people take now. Most contain estrogen and progestin combinations. So there are other forms available. So there are long-acting injectable forms, transdermal contraceptive patch, intravaginal contraceptive rings, implantable rods. That's when we say implantable rods, it's a tiny little piece that people have implanted sometimes under their arm. So how do they work? They prevent ovulation by inhibiting the release of gonadotropins and increasing uterine mucus viscosity. So this results in the decreased sperm movement and fertilization of the ovum and possible inhibition of the implantation of the fertilized egg. They improve menstrual cycle regularity. They decrease the blood loss because they can make people have lighter periods, and decrease the incidence of functional ovarian cysts and ectopic pregnancies. So why else would we use them? So they're primarily used, as we know, to prevent pregnancy, but other uses, sometimes people take them for endometriosis or hypermenorrhea. They take them for the production of cyclic withdrawal bleeding, postcoital emergency contraception. Contraindications. Obviously, if you have an allergy, you shouldn't take it if you're pregnant, if you have high risk for PE. So you see the same kind of, anytime we're talking about hormones, there's a risk of thromboembolism. So I'm sure you've picked that up. So what are the drawbacks to these drugs? Hypertension, thromboembolism, possible PE, MI, stroke. So these are all related to the cardiovascular system and like having some sort of clot, whether it causes a stroke or an MI or a PE. It can alter lipid and carbohydrate metabolism. It can increase serum hormone concentration. So of course, that's why you take them, but you don't want to take too much. So these effects are all from the estrogen component of the medication, not from the progestin. They also can cause this list of things that is common with most of these items. So edema, dizziness, headache, depression, nausea, vomiting, diarrhea, the GI triad, increased appetite, increased weight, breast changes, and many others. So what would we want to avoid? So drugs that decrease the effectiveness of oral contraceptive drugs. Now here's an interesting issue when you think about your patient teaching, because people take an antibiotic and they don't think, oh, my contraceptive might not work as well, but it's true. So you'll hear people say, how did I get pregnant when I was on the pill? What other drugs were you taking? Well, I was on penicillin because I had strep throat. There you go, not as effective. So very important teaching. Barbiturates and then these other drugs. And so drugs that might have reduced effectiveness if given with oral contraceptives. And so this is where these drugs, this list will not work as well if you have an oral contraceptive. Beta blockers, warfarin, tricycline, antidepressants, some vitamins, hypnotics, anticonvulsants, theophylline, and anti-diabetic drugs. So those might not work as well because of having the birth control pill. So osteoporosis, so what do we know? It's because of a low bone mass, increased risk of fractures. It primarily affects women. 40% of women over 50 years of age will develop osteoporotic fracture. 20% with this condition are men. The risk factors, so European or Asian descent have a higher risk, a slender body build, early estrogen deficiency, so you talk about like people that have early menopause, smoking, alcohol consumption, low calcium, sedentary, and if you have a family history. So calcium supplements and vitamin D can be recommended for women who are at high risk for osteoporosis. The current recommendations are that women, especially those older than age 60, consider taking calcium and vitamin D for their bone health. So what are some of the drugs that we're talking about here? So biphosphonates, these work by inhibiting that osteoclast-mediated bone resorption, which in turn indirectly enhances bone mineral density. So osteoclast, we don't want the bone to break down. There's strong clinical evidence that indicates that they can actually reverse lost bone mass and reduce fracture risk. So some of those are Fosamax, Boniva, Actonel, and Reclast. So those are 4 of the drugs that are these biphosphonates that they think actually can reverse. A lot of drugs, can treat a condition, can help prevent, but not necessarily reverse. There are selective estrogen receptor modifiers, SERMs. These stimulate estrogen receptors on the bone and increase the bone density. So, of course, we talk about receptors all the time. So on the bone, there are estrogen receptors. So that's why I remember a few slides back when we talked about, it used to be people took estrogen as a prevention for osteoporosis. And while they don't recommend it, if you're on estrogen for something else, you, of course, are going to be helped in this area because there are estrogen receptors on the bone. So this is a drug that just says, hey, that estrogen you've got, let's stimulate it to get it going a little bit. They stimulate the estrogen receptor modifiers. So that's how it's explained in English. So it stimulates the estrogen receptors on the bone, which increases bone density. So this is Avista and Nolvadex. And then, of course, there's hormones. There's calcitonin, which directly inhibits osteoclastic bone resorption. And Forteo, which is the only drug that stimulates bone formation. It actually stimulates bone formation. It's a derivative of the parathyroid hormone. The Actulin is similar to parathyroid hormone. And then there's Prolia, which is a monoclonal antibody that blocks osteoclast activation, thereby preventing bone reabsorption. So it blocks the bone from breaking down. It is given as a subcutaneous injection every 6 months along with the daily calcium and vitamin D. So they've come a long way in different things they can do, but they have to identify that someone is at risk for this condition before they can implement these issues. And so a lot of this goes back to, are you having yearly checkups and things like that? Especially after a certain age, it's really important that people are reminded to have their annual checkups so they can follow up on these things. So why would we take these? So raloxifan is the primary use is the prevention of postmenopausal osteoporosis. The biphosphonates prevent and treat osteoporosis, and the teriparatide is the subset of osteoporosis at the highest risk of fractures. And so those that have already had a fracture, those are the highest risk. And calcitonin just is a treatment for osteoporosis. So why wouldn't you take these drugs? So the biphosphonates, don't take it if you're allergic, if you have hypocalcemia, esophageal dysfunction, or the inability to sit or stand upright for at least 30 minutes, because people have to sit or stand upright for at least 30 minutes after taking this medication. For the SERMs, if you're allergic, if you're pregnant, if you've had a blood clot, so remember anything related to, it's like estrogen and blood clots go together, including DVT, PD, retinal vein thrombosis, or a history of the disorder. Calcitonin, if you have a drug allergy or if you're allergic to salmon. And then, of course, drug allergy. So, but the denosumab, also if you've had renal impairment or failure or an infection. So what are the adverse effects? With SERMs, again, it has to do with stimulating estrogen. So you might have hot flashes, leg cramps, increased risk of venous thromboembolism. It can be teratogenic, meaning it can hurt if you don't want to take it if you're pregnant. Leukopenia. Biphosphonates can give you a headache, GI upset, which is why you're supposed to sit up. Joint pain, risk of esophageal burns if it lodges in the esophagus before reaching the stomach. So a big thing, that's why you have to stand up. You can't just let it hang out. That's why people have to sit up or be standing when they take this drug. Very, very important. Risk of osteonecrosis of the jaw, possible severe incapacitating bone pain or muscle pain. Calcitonin can cause flushing, nausea, diarrhea, reduced appetite. Teriparatide can cause chest pain, dizziness, hypercalcemia, nausea, arthralgia. And then denosumab can cause infections. So Fosfamax is a very common drug that you'll see a lot of older women are on. It's an oral biphosphonate. It's the first non-estrogen, non-hormonal option for preventing bone loss. It inhibits or reverses osteoclast-mediated bone resorption. The indications are the prevention and treatment of osteoporosis in men and in postmenopausal women, as well as the treatment of glucocorticoid-induced osteoporosis in men and the treatment of Paget disease in women. So I shouldn't have said you'll see a lot of women on it. You'll see women and men on this drug. So Evista, which is a SERM, it prevents postmenopausal osteoporosis, and the adverse effect is hot flashes. Fertility drugs. There are various medical techniques used to treat fertility. So this includes in vitro fertilization and medication, which stimulates ovaries. Clomid and Seraphine are two drugs that are often given. These are non-steroidal ovulation stimulators. So remember, we talk about receptors. So these block the estrogen receptors in the uterus and the brain, resulting in a false signal of low estrogen level. So it says to your brain, hey, it blocks these receptors for estrogen, and so your brain is tricked into thinking, I better produce some more estrogen. So this increases, the brain then increases the production of the gonadotropin-releasing hormone, FSH and LH. So interesting. As a result, the maturation of the ovarian follicles is stimulated, leading to ovulation and increased chance of conception. So Pergonal is a standardized mixture of FSH and LH. It stimulates the development of ovarian follicles, leading to ovulation. It may also be given to men to stimulate spermatogenesis. Chorionic gonadotropin alpha. This is a recombinant form of human chorionic gonadotropin. It causes the rupture and ovulation of mature ovarian follicles and the maintenance of the corpus luteum. And this, again, also stimulates ovulation. So why would we take fertility drugs? It's used to induce ovulation when people aren't ovulating. It can also be used to promote spermatogenesis in infertile men. The adverse effects, it can cause tachycardia, hypovolemia, DVT, dizziness, headache, flushing, depression, restlessness, anxiety, nervous fatigue, lots of different adverse effects that you see there. Blurred vision. These are not without risk, for sure. Uterine stimulants. So what's a uterine stimulant? Pitocin, you hear, oh my gosh, I had to use PIT when I was pregnant. This is what they're talking about. So this is a medication that is used to alter uterine contractions. It promotes labor. It can prevent the start or progression of labor. It's used in postpartum to reduce the risk of postpartum hemorrhage if there are issues with the placenta and things like that. Also called oxytoxics. So oxytocin is a hormonal drug. Prostaglandins, ergot derivatives, progesterone antagonists, RU486. So these are all these drugs. So oxytocin, Pitocin is the synthetic form. So these are used to induce labor or near full-term gestation and to induce labor when contractions are weak and ineffective. Like, hey, you need help, the baby's in trouble, we need to speed this up, we're going to give you some Pitocin. So the other uses are used to prevent or control postpartum uterine bleeding, to complete an incomplete abortion after someone has a miscarriage, or to promote milk ejection during lactation. So it just says, hey, let's go. Essentially, Pitocin is a let's go drug. Prostaglandins are natural hormones. They cause a potent contraction of the myometrium, the smooth muscle fibers of the uterus. They are used to induce labor by softening the cervix and enhancing the uterine muscle tone. So these are some of the drugs, some of the prostaglandin drugs. Ergot alkaloids, these increase the force and the frequency of uterine contractions. These are used after delivery of the infant and the placenta to prevent postpartum uterine from the uterus doesn't work, doesn't go back to how it should, or hemorrhage. And so methergin is one of these, is the name of an ergot alkaloid. And then a progesterone antagonist would be I can never say this word. Mifeprex. Let's go with that. It stimulates uterine contractions to induce abortion, and this can be given with a prostaglandin drug for an elective abortion. Why wouldn't we want these? What are the adverse effects? So there are cardiac effects, hypotension, hypertension, headache, dizziness, fainting, the GI triad, vaginitis, vaginal pain, cramping, and then leg cramps, joint swelling, chills, fever, weakness, blurred vision, lots of issues. So drugs for preterm labor management, and so these are uterine relaxant. These say like, hold up a second, relax, stop. So where the other one said let's go, these say let's stop. These are used to stop labor that began before term to prevent premature birth. They are generally used after the 20th week of gestation. So uterine contractions that occur between the 20th and 37 weeks of gestation are considered premature labor. So the non-pharmacologic measures would be bed rest, sedation, and hydration. So what are some uterine relaxants? So indomethacin is a non-steroidal anti-inflammatory agent, but it also inhibits prostaglandin activity. Nifedipine is a calcium channel blocker. It inhibits myometrial activity by blocking calcium influx. So when they're not effective and delivery is proceeding, then corticosteroids are administered to the mother to promote lung maturity in the fetus between 24 and 34 weeks of gestation. In other words, somebody is in labor, we're telling the body slow down by giving them these drugs to relax the uterus, say hold on, we are not ready, doesn't work, we give steroids if between 24 and 34 weeks to help the lungs. That's it in a nutshell. What are some other things that people would take? So soy. Some people take soy to relieve menopausal symptoms. There's Estrozorb, which could be applied as a lotion. Why wouldn't we? So nausea, diarrhea, abdominal pain, and it remains on your skin for 8 hours. So some things we need to consider when we talk about these drugs. Obviously, we want to do vital signs, weight, blood glucose, and renal and liver function studies. Assess if they smoke, get a really solid history, medication history, assess if they're pregnant. Before giving any uterine stimulants, we're going to assess the mother's vital signs and the fetal heart rate. Before we give a uterine relaxants, they are used only between the 20th and 37 weeks of gestation. You're going to want to follow specific administration guidelines. For biphosphonates, ensure they don't have any esophageal abnormalities, because remember, they need to be able to sit or stand up. Like, that's how important that the drug goes in and gets to your stomach quick. So with estrogen and progestins, we want to take the smallest dose we need and no more than that. If we give an IM dose, it needs to be in the large muscle mass, and we need to rotate the sites. If we give oral dose, it has to be with meals to avoid GI problems. We need to teach patients about correct self-administration and what to do if a dose is missed, for instance, like with birth control pills. Remind patients they have an increased susceptibility to sunburn. Instruct patients to report if they gain weight, and then advise patients to complete annual follow-ups, including their pap smears and breast exams, because we want to catch anything bad that happens quick. With biphosphonates, again, sit up or stand up. They have to drink with a full glass of water, and that's because you need to make sure it doesn't sit in the esophagus. With SERMs, we need to make sure that they know that it has to be discontinued 72 hours before and during any prolonged immobility, like with surgery or a long trip. Monitor for therapeutic response, monitor for adverse effects. Instruct patients taking fertility drugs to take it as ordered and to keep a journal and to watch their vital signs and fetal condition during therapy. So let's move on to men's health drugs. So male reproductive system, several structures, the testes and the seminiferous tubules produce the primary male hormones. The testes produce male sex hormones, and the seminiferous tubules are the site of spermatogenesis, or where sperm originates. Anytime we say genesis, we talk about where something originates. So androgens are the group of male sex hormones, primarily testosterone. Testosterone is responsible for the normal development and maintenance of primary and secondary male sex characteristic. They also develop male and muscle tissue, bone and muscle tissue. So you're seeing a little bit, so testosterone does for the man what estrogen does for the women. Develops the characteristics, is responsible for bone, all these things. It inhibits protein catabolism, so metabolic breakdown. So it helps with the retention of various electrolytes, and it stimulates the production of blood cells. There are several synthetic derivatives. I mean, there are testosterone clinics that all they do is give testosterone shots. Long-term dosage forms can last from 2 to 3 days to 2 to 4 weeks. The oral forms have a first pass effect, have a high first pass effect. So this would be android or halotestin. And there are transdermal forms, patches, and gel. So the anabolic steroids, so they have an anabolic activity. This is a synthesis of the tissue and increasing tissue formation. It's a Schedule 3 because it has a great potential for misuse by athletes because it helps develop muscle. So this would be Anadrol 50, oxandrin, decadurabolin. So the anabolic steroids have approved indications. So these are actually used as an adjunct therapy to promote weight gain after extensive surgery, after trauma, with chronic diseases, anemia, hereditary angioedema, and metastatic breast cancer. So these can be used for other things besides, building your muscles, or what we think about, oh my gosh, somebody abused steroids, why would they do that? But then there are actual good uses for them. So anabolic steroids, great potential for misuse by bodybuilders, weightlifters. They have muscle building properties, serious consequences of sterility, cardiovascular disease, liver cancer. It's a Schedule 3. The misuse can lead to psychological or physical dependence, or both. Danazol is a synthetic androgen. That's the one that's used to treat the angioedema and in women for endometriosis and fibrocystic breast disease. So how do androgens work? They are similar to the body's androgens. They stimulate normal growth and development of the male sex organs, development and maintenance of male secondary sex characteristics. They stimulate protein, aiding in the formation of muscular and skeletal proteins, and enhanced erythropoiesis. The inhibitors block the effects of naturally occurring androgens. These would be 5-alpha reductase inhibitors, BPH treatment, finasteride, and dutasteride. So finasteride, this inhibits 5-alpha reductase, which prevents the thinning of hair caused by increased levels of DHT. So people take this for male pattern baldness. Women also take it. It is not for the treatment of female baldness. It's teratogenic in pregnant women. Use of women of any age is not recommended, and women need to wear gloves when they handle finasteride. So women should not take finasteride at all. I didn't mean to say that. Alpha adrenergic blockers. These are used for the symptomatic relief of obstruction caused by BPH. A lot of very common drugs that you'll see that people are on. So doxazocin, tamsulosin, terazosin. Are you noting a common theme here of SIN? Alfuzosin, tilidocin. And these drugs have the clinical effects of prostate shrinkage immediately. So they're good for BPH. And so the 5-alpha reduction inhibitors may take up to 6 months of continual therapy for the clinical effects of prostate shrinkage. But when people have an enlarged prostate, they have tons of urinary problems, and so you'll see a lot of older males on this drug. Androgen receptor blockers, so they block the activity of the androgen hormones at the target tissue or prostate receptors. They are used for prostate cancer. Here are a few of those. Gonadotropin-releasing hormone analogs. These are also used to treat prostate cancer. They inhibit the secretion of pituitary gonadotropin, which eventually leads to a decrease in testosterone production, which is what people want when as a treatment for prostate cancer. So Zoladex, Lupron, and Trelstar are a few of these drugs. So drugs to treat erectile dysfunction. So PDE inhibitors are used in the treatment of ED. So Viagra was the first oral drug for the treatment of ED. It causes a relaxation of the smooth muscle in the corpora cavernosa, or the erectile tubes of the penis, and permits the inflow of blood. So some other drugs that have come out since Viagra are Levitra, Cialis, and Stendra. So similar to Viagra, but a longer duration of action. Sildenafil and tadalafil are used to treat pulmonary hypertension. And then there's also Caberject, prostaglandin. They're administered by injecting it directly into the erectile tissue of the penis or pushing a suppository form of the drug into the urethra. So lots of different drugs that are used and do things differently. So these are used to replace, and there are other uses that vary with a specific drug, so it just depends on the drug, what the indication is. The contraindications, there are known androgen responsive tumors. So the erectile dysfunction drugs are contraindicated if men have a cardiovascular disorder, especially if they use nitrates such as nitroglycerin. The use of finasteride is contraindicated in women, especially pregnant women and children. So then what are the adverse effects of men's drugs? And so the androgen can cause fluid retention. Anabolic steroids can cause all these problems. Finasteride, all these problems. You can look these up because you're probably going to have to look them over a little. There's just so many of them. Priapism, which is an abnormally prolonged penile erection that causes that requires somebody to go to the ER. There's just so many things, and they are medical emergencies that warrant emergency medical attention. So the priapism is typically caused by an excessive therapeutic drug response. The PDE inhibitors can cause unexplained visual loss, of course, thromboembolic disorders, and heart attack. So anytime we talk about hormones, you see embolism as a problem. So interactions, so the androgens, when used with oral anticoagulants, can significantly increase or decrease anticoagulant activity. Androgens with cyclosporin increase the risk of cyclosporin toxicity. These drugs can cause severe hypotension when given together. The alpha blockers have an additive hypotensive effect when given with other drugs that lower your blood pressure. And the effects of tamsulosin may be increased when taken with azole antifungal drugs, if it's taken with erythromycin and clarithromycin, cardiac drugs such as propranolol and verapamil, and protease inhibitors. So saw palmetto is another drug. It's been researched quite a bit over the years, and this can also be used for BPH and alopecia, which is hair loss. Adverse effects could be GI upset, headache, back pain, and dysuria. So what do we have to remember? Pregnant women should not touch crushed or broken hormone drugs because they can even be absorbed through the skin. You have to educate patients on proper administration techniques for each drug, monitor for therapeutic effects, monitor for adverse effects. Transdermal testoderm patches are applied to the scrotal skin. Transdermal androderm patches are applied to the skin on the body, never to the scrotal skin. Follow exact instructions for sublingual, buccal, or oral forms. Assessment should include complete history, including medication history, urinary elimination problems, and potential contraindications. We're going to want to get vital signs, weight, height, serum electrolyte levels. We're going to want to assess renal and liver function, assess the PSA, and then any current medications that could interact. Okay, let's move on to the anti-neoplastic drugs. We're going to look at cell cycle specific drugs. So cancer, what is cancer? Everyone knows or has been touched by somebody that has had cancer. So it's a cellular transformation. Uncontrolled and rapid cellular growth, it invades the surrounding tissues. It can metastasize to other tissues or organs. The cancerous cells do not have growth control mechanisms. So they don't say, hey, slow down, quit growing. That's a growth control mechanism. It has a positive physiologic function. So cancer cells either grow and invade adjacent tissues, or they break away from an original tumor mass and they travel by means of blood or lymphatic tissue to distant sites. Okay, so what does that mean? So they either are inside a specific tissue and they grow and they invade adjacent. So let's say it's in the liver and then it goes in outside the liver, but right there, adjacent tissue. Or it says, hey, I'm in the liver and I want to go up to the lungs, or I want to go to the brain. So it travels through the blood or the lymphatic system, and now you have liver cancer there. So this is something that people don't quite understand, is when we talk about, people will come in and say, you say, have you ever had cancer? And they say, I've had breast cancer, liver cancer, and bone cancer. So that would be, if somebody said that, that would be, they have 3 primary sites. So cancer is a primary site or a metastatic site. So let's say they say they have liver cancer and lung cancer. That means they had 2 different cancers that we're talking about, that that lung cancer grew in the lung cancer, liver cancer grew in the lung or the liver. But if somebody says, I had liver cancer and it spread to my lung, they had liver cancer in their lung, but the liver cancer cells traveled to the lung through the blood or the lymphatic system. And so when you, like if you were studying to take a test to be certified in oncology, you would have to learn all the expected sites of metastasis, meaning if you have liver cancer, it typically goes here. If you have bone cancer, if you have prostate cancer, it typically goes to the bone, which is absolutely true. A lot of men with prostate cancer, it goes to the bone. If you have breast cancer, it typically goes here. Essentially, so that would be a primary cancer that metastasized to the other organs. That's how you would describe it. But if somebody has two primary sites, that means that that person actually has two separate cancers that can do their own thing, that can travel wherever they want. So that's just a distinction that it's important to know. So there is the primary lesion, which is the original site of growth. Metastasis is uncontrolled cell growth, secondary lesion in a new and remote part of the body. Neoplasm means new tissue. This is a mass of new cells and a tumor. So remember when we were talking about an anti-neoplastic drug? That's what we were talking about. Let's not make new tissue. And then you have a tumor, which can be benign or malignant. Malignant means it's cancer. And so if somebody says, oh, I'm having a biopsy to see if it's malignant, we want to see if you have cancer. And if they say, great news, it's benign, that means it's not cancer. So the tissues of origin, so they can be called, there are so many different names for cancers, but they can be called carcinomas, sarcomas, and then there's lymphomas and leukemias, which are considered liquid tumors. You'll hear in the cancer world them talk about, is it a liquid tumor or a solid tumor? So liquid tumors are the lymphomas and leukemias. They're also known as circulating tumors or hematologic malignancies. And so sometimes people will go to a hematologist for a liquid tumor, not necessarily an oncologist because it's a hematology problem. They circulate. They're circulating tumors as compared to like a mass that's on somebody's pancreas, which would be considered a solid tumor, solid and liquid. So the paraneoplastic syndromes. Paraneoplastic, which means what else sort of looks like it. So this is a various group of symptoms that cannot be directly attributed to the spread of a cancer tumor, but it may be the first sign of malignancy. In other words, they have these things and you're like, it looks like cancer, but we don't see cancer. So cachexia is the most common. Cachexia is, people are so thin. When I did hospice and I would chart about these patients, towards the end, their face, like their cheekbones would be very prominent and things like that. They would have a cachectic look, and that's how I would write cachexia. The person looks cachectic, and people know what that means when you say it. And so sometimes somebody will have that, but you don't know where they have cancer, but you're guessing they probably have cancer because it's very common with cancer. So fatigue, fever, weight loss, and there are other things. So the etiology of cancer. So there could be age and sex-related differences, genetic factors, ethnic, oncogenic pathways, genic meaning the beginning of an oncologic problem, occupational and environmental, carcinogen. A carcinogen is something that develops cancer, radiation, or immunologic factors. So the cell growth cycle. This is super important when we talk about cancer. One of the reasons why is because, like, someone might say, this person had chemotherapy and they lost their hair. This chemotherapeutic drug, you won't lose your hair. And you're like, what? Why would that happen? Doesn't everybody with chemotherapy lose their hair? I mean, it's just sort of a common thing that people think. But no, because it has to do with where in your cell cycle does where in your cell cycle does it have to do with your hair? And if it doesn't affect that area of your cell growth cycle, you're not going to lose your hair. So that's sort of a common fallacy. So the GO is the resting phase, G1 is the first gap phase, S is the synthesis phase, G2 is the second gap phase, and then M is the mitosis phase or the cell reproduction. So different drugs act on different areas of the cell growth cycle. So you might think that you would want drugs that act on all of them so it hits any cycle of the tumor cell replication, but it just depends on the drug. Lots of treatments for cancer: surgery, radiation therapy, and chemotherapy. The nomenclature, lots of different names. So malignant neoplasm is the more technical term for cancer. It's a malignant neoplasm. Anti-neoplastic drugs are drugs used to treat cancer. They're also called cancer drugs, anti-cancer drugs, cytotoxic, meaning kill the cancer cell, chemotherapy, or just chemotherapy. So chemotherapy is a pharmacologic treatment of cancer. So they're anti-neoplastic drugs, and there are drugs, which I was just talking about, that are cell cycle non-specific and cell cycle specific. So they either act on a specific part of that cell cycle or they have nothing to do with the cell cycle. Some drugs do both. So CCS drugs are drugs that are cytotoxic during a specific cell cycle phase. These are used to treat a variety of solid or circulating tumors. Antimetabolites, mitotic inhibitors, alkaloid topoisomerase II inhibitors, topoisomerase I inhibitors, and anti-neoplastic enzymes. And then the cell cycle non-specific drugs are just cytotoxic during any cycle cell stage. There are miscellaneous CCS drugs, and there are miscellaneous anti-neoplastic that are the specificity of the cell cycle is unclear. Hormonal agents, which we just talked about when we talked about estrogen and progesterone and some of the treatments, and then they are radioactive anti-neoplastics. Chemotherapies, these drugs have a narrow therapeutic index. The combination is usually more effective than single drug therapy. There can be drug resistance. Nearly all of them have adverse effects. There are dose-limiting adverse effects. And so when you hear somebody say a dose-limiting adverse effect, that means we have to limit how much of this medication we're giving because of the adverse effect. So you're having these side effects. You'll hear a lot about someone who has chemotherapy and we had to do a dose reduction because I had this. Like my neutropenia was so bad, we have to do a dose reduction during my next chemo. So that's why it was a dose-limiting adverse effect. So it is harmful to all rapidly growing cells. Harmful to cancer cells, harmful to normal human cells, such as hair follicles or GI tract or bone marrow. So it doesn't just say, hey, I'm going to go kill the cancer cells. It just kills cells. It's non-specific. So chemotherapy terms, dose-limiting adverse effects. These are usually in the GI tract or bone marrow, like if someone has such terrible diarrhea they can't continue. If they're in the hospital getting IV fluids after chemo, that's a dose-limiting adverse effect. They can have alopecia, emetic potential, myelosuppression, so bone marrow suppression and depression. This is life-threatening. Nadir. And nadir is where we talk about what is the white blood cell count. It has to do with the white blood cell count. There's extravasation of the drug given IV, and then targeted drug therapy. So that's where we have a targeted drug against a specific therapy. We need to consider toxicities, contraindications, pregnancy, if somebody has not hit puberty yet, and then older adults. So all these different situations require a different train of thought. CCS analogs work by antagonizing the actions of key cellular metabolites. So antimetabolites work primarily in the S phase of the cell cycle, where the DNA synthesis is the most active. There are folate antagonists, which are methotrexate, and then there's others. And then purine, I'm not going to go through all these. Purine antagonists, and then pyrimidine antagonists, 5-FU, very common in GI cancers, gemcitabine. So a lot of very common drugs that are given here, and they all have to do with key cellular metabolites on that cell cycle. So what are some antimetabolites specifically? So folic acid antagonism, so it interferes with the use of folic acid. As a result, the DNA is not produced and the cell dies. See how important folic acid is? Purine antagonism, this interrupts the metabolic pathway of the purine nucleotides. It results in the interruption of DNA and RNA synthesis, and tumor lysis happens. Tumor lysis meaning kill the tumor. So this is what I mean by it doesn't just do this to the cancer cells. It does this to their DNA and their RNA and the folic acid. It just happens. And so there's all these other effects of we killed the cancer, but we also killed these cells. So sometimes say, you know, the cancer didn't treat me, but the treatment did. You'll hear a lot of people say that, you know, the long-lasting effects and things are terrible. pyrimidine antagonism. So this interrupts the metabolic pathway of the pyrimidine base, and this results in the interruption of DNA and RNA synthesis. So why would we use an metabolite? So it is used in combination with other drugs to treat various types of cancers, such as it's used for solid and liquid tumors. It's used for acute and chronic lymphocytic leukemia, several types of leukemia. It's also used for colon, rectal, breast, stomach, lung, and pancreatic cancer. There are oral and topical forms which can be used for low-dose maintenance and palliative cancer therapy. It's often used in combination chemotherapy. And methotrexate is something you'll also hear about, people going to get their methotrexate infusion if they have psoriasis, or some people get monthly treatments for rheumatoid arthritis. So there are other uses for some antimetabolites. What are the adverse effects? They can cause hair loss, nausea, vomiting, myelosuppression, all these. Neurologic, there's almost nothing that isn't touched, right? Tumor lysis syndrome, the Palmer-Plantar dysesthesia, which is also called hand-foot syndrome, Stevens-Johnson syndrome, toxic epidermal necrolysis. So, in other words, also can cause a lot of skin problems. So, tons of problems with these drugs. Let's move on to mitotic inhibitors. And so these are natural products obtained from the periwinkle plant. So these are the vinca alkaloids, vinblastine, vincristine, vinorelbine. And then there are also taxanes, paclitaxel, docetaxel. So very common drugs that are given, all from a plant. So how do they work? They can work in various phases of the cell cycle. So remember the other one we're mainly on the S phase. These are the late S phase, throughout the G2 phase, and the M phase. And so why would that be better, right? It's better to hit more frequently on the cell cycle, because you're just going to be able to, it's just going to work better because it's hitting more areas of the cell cycle is what I'm trying to say. So they all work shortly before or during mitosis, and so they retard the cell division, which is wonderful. We don't want these cells to keep dividing and dividing and dividing. Each different subclass inhibits mitosis in a different way. It's often used in combination with other drugs. It's used to treat a variety of solid tumors and some hematologic malignancies. So it's used for testicular, small cell lung, breast, ovarian, non-cell, Kaposi syndrome, and then for acute leukemia. The adverse effects: hair loss, nausea, vomiting, myelosuppression, liver, kidney, and lung toxicities, convulsions, and it can cause extravasation. So there are several specific antidotes that can be used if somebody has an extravasation of one of these drugs in their IV. So another area is an alkaloid topoisomerase II inhibitor, and this is used to treat small cell lung cancer and testicular. It's not used as much now because there are significant toxicities without a significant therapeutic benefit, essentially. So the benefit does not outweigh the risk. That's the bottom line with these. So topoisomerase I inhibitors are also called camptothecans. These are primarily used to treat ovarian and colorectal cancer. They are derived from camptothecin, which is a substance taken from a Chinese shrub. So topotecan or irinotecan are the two drugs. These are CCS drugs, which means they're cell cycle specific. They inhibit the proper DNA function in the S phase. They prevent DNA relegation, and they are indicated for ovarian and colorectal, small cell lung cancer, and other tumors. The adverse effects: so topotecan, BMS, mild to moderate nausea, vomiting, diarrhea, headache, rash, muscle weakness, and cough. The irinotecan causes more severe adverse effects with hematologic adverse effects, cholinergic, diarrhea, a moderate risk of nausea and vomiting. So anti-neoplastic enzymes is a different area. These are synthesized using cultures of bacteria and recombinant DNA technology. As a result, voila, we have an enzyme. The enzyme is isolated and purified for clinical use. So Elspar is a drug that's used to treat acute lymphocytic leukemia, and then Oncaspar And then we also have asparaginase, which is available only by special request from the National Cancer Institute for patients who have developed an allergic reaction to E. coli-based asparaginase. So this is only indicated for acute lymphocytic leukemia. The adverse effects are impaired pancreatic function, which can lead to hyperglycemia or severe or fatal pancreatitis, dermatologic, hepatic, GU, neuro, musculoskeletal, GI, and cardiovascular effects. Lots and lots of nursing implication when it comes to oncology drugs, and that's why like oncology nurses are typically certified, and it's quite a bit to go through, but it's super interesting and it's an amazing field. So we're always going to want to assess those baseline blood counts before we administer an anti-neoplastic drug. We're going to follow the specific administration guidelines. Remember that all rapidly dividing cells, both normal and cancer, are affected. So your mucous membranes, your hair, and your bone marrow. We're going to monitor for effects of these tissues or complications. So GI mucous membranes, people can get stomatitis, which is, there's a lot of things that we give to counteract these issues. Altered bowel function with a high risk for poor appetite, nausea, vomiting, diarrhea, inflammation, and possible ulcerations of GI mucosa. Monitor for complications, so with hair follicles, loss of hair, and then bone marrow complications. So there could be life-threatening low blood cell counts. We're going to monitor for the specific effects for the type of anti-neoplastic drug given. We're going to implement measures to monitor for and prevent infection if they have neutropenia or leukopenia. We're going to monitor for or prevent bleeding in patients with thrombocytopenia and anemia. Keep in mind the anemia can result in severe fatigue. And so with stomatitis, which is this oral inflammation and ulcerations, implement measures to reduce the effect. Anticipate nausea and vomiting and implement measures to reduce the effect. And antiemetics, if they're given 30 to 60 minutes before chemo is started, it can help. Women of childbearing age will need to use a non-drug form of contraception. In addition to physical measures, we need to keep in mind the need for emotional support and then monitor for a therapeutic response. So a lot of what they were talking about when we do, and I've talked to you guys about clinical research before, and I did clinical research for a long time, and I worked in oncology clinical research the most. And the one thing that they find with research, which is amazing, is they know, the reason we know that we need to give these drugs 30 to 60 minutes before, with each drug regimen. So you know how they're talking about this drug will be given in combination with that, et cetera, et cetera. So either with each individual drug or with each drug regimen, they now know this is exactly what people have to take beforehand to prevent this, or to at least help alleviate this. And so some people will need steroids or Reglan or Benadryl, certain things before they give the drug, and it'll be very specific with when. It won't just say, hey, give it before. It'll say give it 15 minutes before, give it 30 minutes before, give it an hour before. You know, take it the day before, take it for 4 days after. So there are so many drugs that are given to support people with chemotherapy to avoid all these adverse effects, or at least to lessen them. And each one has their own, and that's because of years of clinical research on these items. Okay. So let's go part 2, the non-specific drugs, and so they are not specific to the cell cycle. So these are anti-neoplastic drugs such as alkylating agents and cytotoxic antibiotics. So an alkylating drug would be a classic alkylator like nitrogen mustard, nitrosoureas, and then there are miscellaneous alkylators. Alkylating drugs work by preventing cancer cells from reproducing. So we want to stop that constant reproduction of the cancer cell. They alter the chemical structure of the cell's DNA. They are bifunctional or polyfunctional. They are used in combination with other drugs such as all these: ovarian, brain, lymphomas, leukemias, so liquid and solid tumors, breast and bladder, and others as well. So the adverse effects, so dose-limiting adverse effects, which again, we might have to give less of the drug, which if you give, people can get really upset if you tell them we have to reduce the drug, the dose, because imagine you have a headache and 2 Tylenol work, and somebody says, we can only give you 1 headache, 1 Tylenol this time. You're like, oh my gosh, I hope it actually helps my headache. Well, imagine if you had cancer And they say, this is the dose you need. And then they're like, well, you've had this first effect. We're only going to give you half the drug. It's very emotionally upsetting for people. Alopecia, nephrotoxicity, peripheral neuropathy, and ototoxicity. So hydration can prevent nephrotoxicity. And then extravasation can cause tissue damage and necrosis. So some examples of an alkylating drug would be cisplatin, treats solid tumors. Cytoxin treats bone, lymph, blood, and solid tumors. And so cytoxin can treat liquid and solid tumors. This nitrogen mustard treats Hodgkin's and Hodgkin's lymphoma, which is a liquid tumor, and then others as well. Cytotoxic antibiotics, and so these are natural substances produced by the mold Streptomyces. So this is a semi-synthetic substance that's used. Bone marrow suppression is a common toxicity. Bleomycin causes pulmonary toxicity. Like, it is a known thing that if someone gets bleo, you have to watch their lungs. Daunorubicin can cause heart failure. Doxorubicin, specifically in the heart, causes left ventricular failure. So again, research after all these years, we know these specific things that we know to watch for with these patients. Cytotoxic antibiotics are active in all phases of the cell cycle. They act by intercalation, resulting in the blockade of DNA synthesis. They are typically used in a combination chemotherapy regimen. They are used to treat a variety of solid tumors and some hematologic malignancies or liquid tumors. They also can treat an AIDS-related Kaposi sarcoma when they are intolerant to other treatments. So what are the adverse effects? Of course, bone marrow suppression, except bleomycin doesn't, but you might have pulmonary problems. Hair loss, nausea, vomiting, myelosuppression, heart failure, acute left ventricular failure, pulmonary fibrosis, and pneumonitis. But you see there's specific drugs for these. Liver, kidney, and cardiovascular toxicities. So cardiomyopathy is associated with large amounts of doxorubicin. So they will have a routine monitoring of their cardiac ejection fraction with multi-gated acquisition scans, cumulative dose reductions, and then cytoprotective drugs such as dexamethasone, which can decrease the incidence of this devastating toxicity. So when I was doing clinical research on doxorubicin, we had to know what their ejection fraction was beforehand, because as a baseline to even get into a study to take this drug. What are some miscellaneous anti-neoplastics? So Avastin is an angiogenesis inhibitor. Angiogenesis, right, the beginning of the cells. It blocks the blood supply to the growing tumor, so it cuts off the blood supply. It is used to treat metastatic colon cancer, rectal cancer in combination with 5-FU, fluorouracil, that's referred to as 5-FU, non-small cell lung cancer, and malignant glioblastoma. There are many adverse effects, including nephrotoxicity. Sandostatin treats carcinoid crisis, and this is the treatment of the diarrhea caused by vasoactive intestine peptide secreting tumors. Hydroxyurea or hydrea is similar to an antimetabolite. It's used to treat squamous cell carcinoma and some leukemias. Many adverse effects, as you see here. And then Gleevec is used to treat chronic myeloid leukemia, CML, which is a targeted therapy, but it's not a monoclonal antibody. It works by inhibiting an enzyme that's active in the CML process. So when we say it has a targeted therapy, it's not a systemic therapy. It's targeted. It works on the enzyme that has to do with the CML process. It can be used with other hepatic metabolized drugs that cause severe interactions. So we have to be careful if we use them with the hepatic metabolized drugs, because they might not work as well, or they might have more side effects. There are many adverse effects and drug interactions. Mitotane is an adrenal cytotoxic drug used specifically for the treatment of an inoperable adrenal corticoid carcinoma. It's oral. The adverse effects are CNS depression, rash, nausea, vomiting, muscle weakness, and headache. It also reduces the effects of warfarin and phenytoin. There are hormonal drugs that are used to treat cancer, just like we just talked about. They treat a variety of neoplasms in men and women to oppose the effects of hormones or to block the body's sex hormone receptors. They're used most commonly as an adjuvant and palliative therapy, but they can be the first drug of choice for some cancers. So the hormonal drugs for female-specific neoplasm, aromatase inhibitors, selective estrogen receptor modulators, tamoxifen, progestins, which we just talked about, androgens, and then estrogen receptor antagonists. So for males, the anti-androgens, and then the anti-neoplastic hormones. Extravasation. And so when you learn about IV therapy, you'll learn about we always want to prevent extravasation of the drug. So that can be harmful. You know, it can hurt to have extravasation of anything, but if you leak an anti-neoplastic drug into the surrounding tissue with an IV, it's very bad. When you have an extravasation, it can result in permanent damage to the nerves, tendons, muscle, loss of limb. They can need skin grafting, amputation. Prevention is essential. So continuous monitoring of that IV site is essential. If suspected, you would tell the patient, if you feel anything at all, you have to tell me right away. So if suspected, you're going to stop the infusion immediately and contact the prescriber, but leave the IV catheter in place. You do not want to take it out. You're going to aspirate any residual drug or blood from the catheter. You're going to consult the guidelines or the pharmacist regarding the antidote, whether you need a hot or cold pack, or sterile occlusive dressing, elevation, rest of the affected limb. You're going to thoroughly document the extravasation event and consult the facility protocols and guidelines. So what are our nursing implications? We need to assess blood counts. We need to follow the specific administration guidelines. For alkylating drugs, you're going to monitor for the effects of bone marrow suppression. Expect nausea, vomiting, diarrhea, stomatitis. Hydration is important for nephrotoxicity to prevent it. They could report ringing or roaring in the ears, possible ototoxicity. They can report tingling, numbness, or pain in the extremities because also people can get peripheral neuropathies. For cytotoxic antibiotics, again, bone marrow suppression, nausea, vomiting, diarrhea, stomatitis. Those are all the things because of that's just where they act. Pulmonary status, because pulmonary fibrosis may occur. We're going to monitor the kidney and the liver and the heart. Danirubicin may turn the urine a reddish color, so you want to tell people that. In general, we're going to watch for an anaphylactic reaction. We're going to keep epi, antihistamines, and anti-inflammatory drugs on hand. We're going to monitor closely for the complications. The cytoprotective drug may be used to reduce toxicities. So IV amifostine reduces the renal toxicity associated with cisplatin. IV or oral allopurinol to reduce hyperuricemia. And then we're going to monitor for oncologic emergencies, such as an infection, pulmonary toxicity, allergic reaction, stomatitis with severe ulcerations, bleeding, metabolic aberrations, bowel irritability with diarrhea, renal, liver cardiac toxicity. So last but not least, let's go over the immunosuppressant drugs. So the immune system distinguishes itself from non-self and protects the body from foreign materials, including cancer. There's humoral immunity, which is mediated by B lymphocytes, and cellular immunity, which is by T lymphocytes. These participate in anaphylactic reactions. They are responsible for the kidney, liver, and heart transplants, and they can also attack itself, causing an autoimmune disease or immune-mediated disease. So immunosuppressants are drugs that decrease or prevent an immune response. They are used to prevent or treat when someone has a transplant. There's immunosuppressive therapy. It also can be used for RA, systemic lupus, Crohn's, multiple sclerosis, myasthenia gravis, psoriasis, and others. They also suppress certain T lymphocyte cell lines, thus they prevent their involvement in the immune response. They result in a pharmacologically immunocompromised state, and the mechanisms of action vary by the drug. So there are therapeutic uses that vary from drug to drug, primarily indicated to treat organ rejection. You see this list here that are used, and there are major classes that are used to treat, to prevent organ rejection. Glucocorticoids, calcineurin, inhibitors, antimetabolites, and then biologics. So you can look at all these details. This is the major class to prevent organ rejection. All these drugs can be used. Lots of drugs to be used for organ rejection. Imuran is prophylaxis of organ rejection concurrent with other immunosuppressant drugs such as cyclosporin and corticosteroids. The adverse effects, you can get lymphoma and other malignancies, as well as hepatosplenic T-cell lymphoma. And then Simulect and Xenipex are monoclonal antibodies they use to prevent rejection of transplanted kidneys. They're used as part of a multi-drug immunosuppressive regimen that includes cyclosporin and corticosteroids. They tend to have cause an allergy-like reaction known as a cytokine release syndrome. Two others, so Simulect and Xenipex, these are a cytokine release syndrome. They can be severe, and even people can have an anaphylactic reaction. They're often, because of that, they're often pre-medicated with corticosteroids in an effort to avoid or alleviate that problem. Basiliximab has a black box warning for I can't talk by the end of this. Lymphoproliferative disorder and opportunistic infection and severe hypersensitivity reaction, including anaphylaxis. Cyclosporin prevents organ rejection, and it can be used with other autoimmune disorders, but it does have the black box warning of renal damage and increased risk of serious and fatal infections. So an orthoclone, OKT3, reverse and prevents graft rejection. It's a monoclonal antibody. It specifically targets the binding sites on the T cells that recognize something as a foreign invader, such as a transplanted organ. CellCept is indicated for the prevention of organ rejection as well as the treatment of organ rejection. It has the FDA warning for increased risk of congenital malformations and spontaneous abortions if it's used with pregnancy. Lots of side effects. Copazone works by blocking T-cell autoimmune activity against myelin protein, which reduces the frequency of the neuromuscular exacerbations associated with MS. Gilenya is an anti-rejection drug. It's approved in 2010 for MS. It failed as an anti-rejection drug, so it's only used for MS. Significant adverse effects. It blocks the T-cell autoimmunity activity against the myelin protein, which reduces the frequency of the neuromuscular exacerbations that we see with people with MS. For transplants, it helps with all these different types. Rejection is a primary concern. It occurs from an immune response targeted against that transplanted organ. Immunosuppressants are used to inhibit the immune system and prevent organ rejection. They are on these immunosuppressant therapies for their entire life, and the cost of this can be more than $2,500 a month. Miscellaneous. So Rapamune is a macrocyclic immunosuppressive antifungal anti-tumor drug. It's oral, and Prograf, calcineurin inhibitor, and it's oral and injectable. Adverse effects vary according to the drug and can be devastating. You imagine if you're shutting down your immune system. So all immunosuppressed patients have a heightened susceptibility to opportunistic infections. The nursing implications, you need to perform a thorough assessment before administering immunosuppressants. All these different things need to be done. You're going to assess, of course, for an allergy, an interaction, a contraindication. You're going to want to always be monitoring their white blood cell count, because if it drops below a certain range, then they're really in trouble, and we have to put certain things in motion. So oral immunosuppressants should be taken with food for GI. Oral forms used when possible to just decrease the risk of infection that can occur with a parenteral injection when they already don't have a great immune system. There are several drug interactions. Grapefruit juice interacts with many drugs. Oral antifungal drugs are usually given to treat the oral candidiasis that can occur. Always assess the oral cavity for this. You're going to mix oral cyclosporin solution in a glass container. Do not use styrofoam because it adheres to the inside walls of the container. Follow the guidelines when you give an IV and inform them that it's a lifelong therapy. Patients should be encouraged to take measures to reduce infections, such as avoiding crowds or people with colds. Inform people to immediately report signs of an infection. We're going to monitor to make sure they're working and monitor for adverse effects. And this was all taken from your book. I hope you have a wonderful day.